Hello and welcome to another episode of Ultrasound Podcast, where we bring together the best minds of ultrasound from around the globe. Today we have an amazing guest with us. He is none other than Dr. Ross Prager, all the way from Ontario, Canada. Ross has been a phenomenal name in critical care, echocardiography, ultrasound, medical education, and research. It's a great privilege having him with us. Without further delay, please join me in welcoming the extraordinary Dr. Ross Prager from Canada.
Thanks, Ross, for joining us. It's a great privilege having you here. Cardiac tamponade.
Thanks so much for having me.
No worries. So cardiac tamponade is such an important topic, and you have got so many presentations and articles on it. I thought I'll pick your brain. Before we get into the details, let me talk about one of my patients that I have seen recently. So this was a 63-year-old man who presented with some epigastric pain and some chest pain and palpitation. So he did the bedside echo, and it was a part of this E-fast scan, and that is what we found. It seemingly looks like a very happy swinging heart, but it was not a happy condition. And that is what we are this is what we are going to talk about over the next few minutes. So Ross, you have got publications on this topic, and there are some of the very interesting aspects of it, including the transesophageal echocardiography. So before we get into the detailed factors or presentations of the cardiac tamponade, please tell us a little bit more. What is it?
Yeah, and just thanks again for having me. When I think about cardiac tamponade, I really just think of it as a pericardial effusion with organ dysfunction. Now, sometimes there's more traditional definitions where there has to be systolic hypotension, for example. But unlike what we were probably taught in medical school, tamponade really is not a binary diagnosis. It exists on a spectrum, from a pericardial effusion causing mild congestive organ injury, maybe mild AKI, mild dyspnea, all the way to the patient who's arresting because they can't fill their heart and their cardiac output's close to zero and they're having a cardiac arrest in the setting of trauma or any other cause. And when you view pericardial tamponade along a continuum, it starts opening up the question of at what point should you intervene? And that's one of the things that I'm looking forward to exploring today.
Excellent. Thank you. So what is the mechanism? How this happens?
Yeah. As the pericardial pressure rises, filling into the heart actually becomes impaired. And eventually it becomes so impaired that forward flow and stroke volume is limited. And there's this concept of kind of interventricular dependence, where when a heart has a pericardial effusion around it, there's only so much blood that can be in the heart at any given time. So as we start filling in one side of the heart, we have to kind of compromise, and the filling of the other side of the heart will actually drop. And we'll actually see a dropping kind of stroke volume, for example, on the left side as the right side fills. And this gives rise to the classic pulsus paradoxus that we see and we talk about so often, where during inspiration, there's actually a drop in blood pressure because during inspiration, we bring blood into the right side of the heart. But because of that ventricular interdependence and because there's kind of that fixed pericardium, stroke volume on the left side actually decreases. And you know what, the exact pressure on the screen here, it's 10 or 20 kind of millimeters of mercury. The exact pressure doesn't really matter because it exists on the spectrum. So even at pressures that might not cause the classic echo features of tamponade that we're going to talk about, you could still potentially have organ injury from the pericardial effusion.
So with regards to the pressure, you said that it can be, even if it is below 10 millimeter of mercury, still you can have cardiac tamponade. That is what you meant?
Exactly.
Yep.
I mean, rarer at lower pressures, but some of it, as you've shown here, it depends on the chronicity of the effusion. Chronic pericardial effusions are much better accommodated than acute pericardial effusions because over time the pericardium can actually stretch and accommodate more and more volume. So the image that you showed at kind of the first slide here with that massive pericardial effusion and the swinging heart, that was a chronic effusion that's probably been going on for months or even longer. Versus in trauma, a very small pericardial effusion, if acute enough, can actually cause the same physiology that you would see with a larger effusion.
Yeah, that is such an important point to for our viewers that even if in case of the acute trauma, even if a small pericardial effusion, that can lead to cardiac tamponade. So we have got different types of diagnostic tools instead of just focusing on one aspect of it. What are the different diagnostic tools you find useful for the diagnosis of the cardiac tamponade?
Yeah. It starts with kind of history and physical. So is there a reason to suspect pericardial tamponade? So I suspect it at least partially in all patients with shock, because missing pericardial tamponade, which is such a reversible cause, is just so harmful. And so any patient with undifferentiated shock, and then there's certain populations where I might think more about tamponade or pericardial effusions in general. And that would be oncology patients presenting with shock, chest pain, hypotension, trauma patients, any of them presenting with hemodynamic instability, and then also patients that are chronic dialysis patients that might have uremic pericardial effusions as well. Once we've kind of suspected pericardial tamponade based on history, we can move to physical exam. And the classic features of tamponade, elevated GVP, muffled heart sounds, Beck's Triad, hypotension, and all of that, unfortunately are fairly insensitive to predict tamponade. Now, if I do see an elevated GVP and hear muffled heart sounds and the patient's hypotensive, I'll certainly put the ultrasound on. But the test characteristics for those physical exam maneuvers are not enough to rule it out or rule it in definitively without additional testing anyways, meaning that you probably, if your pretest probability was high enough to think about tamponade, should be putting an ultrasound on the chest. But before we get to ultrasound, you can also look at filling pressures of the heart, so central venous pressure, for example, and also even if you had a pulmonary artery catheter on there. There's some classical findings on PA catheters where all the chambers start the pressure in the different chambers start approaching the same value. On CVP, we can start seeing the CVP rising as the filling pressure required to fill the pericardium increases. But these are not particularly specific because they can be seen in other causes of shock, for example. And so I wouldn't rely on them. The mainstay of diagnosis is putting an ultrasound on the heart and on the chest. And depending on your setting and your skill set, that could be getting a formal cardiology performed or echocardiographer performed ultrasound, or if you have the skill set yourself, placing the probe on and performing point-of-care ultrasound. And I think this is probably one of the most canonical applications of point-of-care ultrasound. It's easy to do, it's accurate to rule out tamponade, and it's something that every acute care clinician should feel comfortable doing because the implications of diagnosing or missing tamponade are profound. And so even just with the 2D kind of pericardial effusion, yes or no, that gets you a lot of the way there. And then there's some more kind of advanced echocardiographic features that we'll talk about and that you can look at on ultrasound to really kind of differentiate it further.
Excellent. Thank you. So you have got quite a few cases over the years that you have presented in different platforms. Let's go through them one at a time. Is that okay with you?
Absolutely. And hopefully there's a couple take-homes from each of them.
So there was this a patient who presented with some chest pain or discomfort, I believe. And this is the echo. Tell us about this patient, if you can remember.
Yeah. And so this patient presented with kind of just shock and circulatory collapse on the background of subacute dyspnea. And I just want to take this as an opportunity to go through the echo features of tamponade that we're going to see on this echo and potentially some of the future ones. So the first is the presence of a pericardial effusion. These are typically hypoechoic. However, in the setting of, for example, clotted blood, they might actually be more isoechoic as well. But most of the times, they're dark. The next thing that we can see in this image is that kind of rocking of the heart. That rocking of the heart indicates a very large effusion, and it's interesting because that is the echocardiographic correlate to the ECG finding electrical alternans that we talk about, where intermittently QRS complexes are getting bigger and smaller. And that's because as the heart moves, the axis of the heart relative to surface ECG electrodes changes, and thus the ECG amplitude will change over time as well. Other things that we can see here, although it is a little bit harder to see potentially is that the RV during diastole is collapsed. This is a hallmark of pericardial tamponade. During diastole, the RV should be filling, but because of the high pericardial pressure, there's actually pressure pushing on the RV free wall and collapsing it in, preventing filling. And this is the pathophysiology of pericardial tamponade and how it leads to shock and hypotension. And then there's RA systolic collapse. Now, RA systolic collapse used to always confuse me because I was like, well, if the right atrium is in systole, shouldn't it be collapsed? But remember, we're talking about ventricular diastole. So during systole, the right atrium should be filling because the tricuspid valve is closed. And so in this situation and in tamponade, when the right atrium is meant to be filling, it's actually collapsed as well. Now, there's other echocardiographic features that you can look at: tricuspid valve variation, inflow variation, mitral valve inflow variation. These are getting a little bit more advanced, but the idea goes behind that ventricular interdependence. And so when you have a fixed pericardial effusion that's constricting the inflow of blood, it's a zero-sum game. As the right side fills, the left side can't accommodate as much blood. And as the left side fills, the right side can't accommodate as much blood. So this trade-off during the respiratory cycle causes there to be exaggerated changes in the filling of the ventricles during inspiration and expiration. And the exact thresholds between the mitral valve and tricuspid valve are different, and there's actually differences in the literature, but the concept is key, and it all relates to this concept of ventricular interdependence. And then the final echocardiographic feature that isn't talked about as much, that we definitely will talk about, is the idea about measuring a left ventricular outflow tract, or LVOT, velocity time integral. And the LVOT VTI measures a continuous column of blood leaving the left ventricle and is actually a fantastic surrogate for stroke volume. And as the pericardial effusion becomes more significant, we might start seeing the VTI decrease. And when I see a pericardial effusion with a low VTI, even in the absence of some of the other features of tamponade, I might still think that this is a very important pericardial effusion and is probably causing some degree of organ failure. And the term that we use for that is tamponade, but you can also just think of it like a pericardial effusion causing organ failure. That's all that tamponade is.
Exactly. So thanks for explaining all these features of cardiac tamponade or pericardial tamponade. It's amazing to see all these features are present in the same patient. And I was just wondering what happened at the end result of this patient.
Yeah, the patient had the pericardial effusion drained. Now, when you have a massive pericardial effusion like this, you have to be a little bit careful because if you drain it too quickly, you can actually run into issues. For example, if there's a concomitant pulmonary hypertension, the RV is used to being compressed in, but when you drain the effusion, if you drain it too quickly, the RV can actually start ballooning out and you can get RV failure. So this is a patient that I probably wouldn't drain the entire effusion all at once. I would drain enough to restore hemodynamics and improve hemodynamics, and then kind of monitor that and drain off, say, 500 mils or 300 mils, because I think this was a liter or more of fluid in the pericardium here.
And looking at the size, it looks like this is another chronic case, isn't it?
Correct. Yeah, this was malignancy associated.
Mm-hmm. And you have mentioned about this swinging heart sign, which correlates well with the electrical alternance, which is an amazing thing. So every time I look at the electrical alternance in the ECG, I think we are going to get a very interesting picture in the echocardiogram, or a clip in the echocardiogram.
Yes. And I think I'd just add that if you see a swinging heart in a pericardial effusion, almost certainly there's a hemodynamic impact of that. So you could spend time trying to measure mitral valve inflow and tricuspid valve inflow, but if the heart's swinging because in the effusion, you have tamponade, if the clinical syndrome suggests it, which I've never seen a case where the heart's swinging where there is not some degree of organ dysfunction related to that effusion.
And there is this another patient of yours.
Yeah. And so in this picture, I guess what I'd probably just want to draw your attention to more so first you can see that the heart is swinging here, and there's kind of that same motion that would produce electrical alternans. Also, the RV free wall on the top of the screen, because this is a peristernal long axis, it looks like somebody's jumping on it. So when the RV is meant to be filling during diastole, it really looks quite compressed and flattened. So again, that's classic for tamponade there. And then there's a hyperechoic structure entering into the pericardium from the left-hand side of the screen on the top. And that hyperechoic structure on the top of the screen there, I believe that's a guide wire actually that's been introduced as part of the pericardiocentesis. And so this was probably during active pericardiocentesis to confirm the placement of the guide wire. And so there's different ways to confirm for pericardiocentesis. One of them is to look at the guide wire to make sure it's in the right position. And then often we'll also do a flush with some bubbles. And so one thing we might do is when we get the needle into the pericardium, if we're using an angiocath that has a plastic sheath on it, we'll put the plastic sheath in the pericardium, flush, visualize bubbles in the pericardium, and then put the guide wire in, just to be extra certain that we're not dilating the right ventricle or the left ventricle. Because if you dilate the right ventricle, unlike the left ventricle, that the muscle's thick enough that it typically kind of seals off on itself, the right ventricle, you often tear it, and that can cause a lot of problems and a lot of complications that need repair in the OR.
Excellent case. Thank you for sharing that. And you have got this another interesting case, Ross. Please talk us through.
Yeah, so in this case, this is a peristernal long axis. And so the top of the screen, you can see that there's a pericardial effusion, maybe 1 to 2 centimeter pericardial effusion, and then the right ventricle below that, and then the left ventricle below that. And compared to the previous ones, this is a little bit less obvious, but something that should really catch your eyes is the free wall of the right ventricle. During diastole, when it should be expanding up, it really looks like something's kind of pushing down and indenting it. So this is classic RV diastolic collapse. And this is more of the kind of classic features of tamponade when they're not quite as exaggerated as they were on the previous videos.
And Ross, so you mentioned about diastole. That is such an important thing to interpret. But usually the echocardiographers or the cardiologists, they do an ECG. Do you, what is your practice? Do you do the ECG as well at the same time to correlate which phase of the cardiac cycle this is?
Yeah, not always actually. And so often we just don't have an ECG available, or if you're in the thick of it. And so if you don't have an ECG available, what you can do is you can actually freeze the image frame by frame and look at the mitral and the tricuspid valve. And so during diastole, the mitral and tricuspid valve are open because the ventricle is filling. And so during systole, on the other hand, these valves are closed. So what I do is I first find systole when the valves are closed, and then the free wall of the RV when there's a pericardial effusion during systole often looks collapsed because it really exaggerates the free wall. And so it looks indented. But then as the mitral or tricuspid valve and the mitral valve open, the RV wall should come up and stay up during the entire course of diastole. But what you'll see in tamponade is that RV free wall will come back in again, particularly during like later diastole often, and you'll start seeing that diastolic collapse. And that's what we're seeing here if we could freeze the clip, frame by frame.
That is such an interesting tip to correlate the ventricular component of the cardiac cycle with the mitral valve and tricuspid valve. That is fantastic. Thank you. And you have got this lot of fibrin or lot of fibrin threads around the heart. Talk us through, please, Ross.
Yeah, just like a pleural effusion, pericardial effusions can be kind of complex or simple. And so many of the pericardial effusions we encounter are simple, but sometimes you'll start seeing fibrin stranding. And so the cause of this, similar to a pleural effusion, really depends on the context. So again, going to a pleural effusion in the lung, it could be a hemothorax, an empyema, just a perineumonic effusion with a lot of kind of fibrin stranding. And the same thing kind of applies to the heart. You can see some stranding in there from blood in the pericardium, hemopericardium, from infectious causes, be that bacterial or other, or just very inflammatory or more chronic effusions where these fibrin strandings form. It doesn't necessarily change your approach to the patient if the patient has severe shock and hypotension. If a patient's in fulminant tamponade and they're imminently going to arrest, you have to put a needle in, you have to drain it. But if we see these really complicated effusions in a patient that has a disease process that might make you think of an infection, you have to start asking yourself, does this patient need a pericardiocentesis, or is this a patient better served by a pericardial window, for example? And maybe a surgeon needs to go in there, open up and kind of make a bigger incision and really kind of get that out. I remember seeing a case of actinomyces related pericardial effusion, and it looked almost identical to this. This wasn't the case, But in that situation, it was a big discussion. Do we stick a needle in and try to drain it for kind of purulent pericardial effusion? And the answer was no. Let's just go to the OR, let's debride it, let's open it up, wash it out, and kind of get rid of all the infection from there. And so that's something that I keep in the back of my mind when things look really complicated, particularly if the patient has had it for a longer time, because often even then, the pericardiocentesis is not quite as effective as it is for kind of a more acute effusion, at least in my experience.
Thank you, Ross. Quick question, and I think I'll struggle myself about identifying whether there is right ventricular collapse or the right atrial collapse. The sonographic features of cardiac tamponade is in a patient who has got a lot of this fibrin. How do you have any tips or tricks to identify the cardiac tamponade in this type of cases?
I don't think I haven't found it too much different in terms of interpreting it. It can be subtle, absolutely, but I haven't found that the fibrin necessarily influences the collapse or the kind of the free wall kinetics. At least not something that I've noted. Have you seen any differences between them?
Not really. But as I've said, that in a patient who does not have this type of fibrin, I will probably identify the right atrial collapse, right ventricular collapse, swinging of the heart more obvious. But in this case, there is no swinging at all because they are all connected to the wall of the pericardium. And there is probably right atrial collapse and right ventricular collapse. But as you have said, that these are subtle changes, not quite very obvious.
And for me, I would just really focus on this case at looking at the clinical picture, right? Tamponade is such a clinical diagnosis.
Absolutely.
And so does this patient have renal failure as a result of this effusion? Do they have borderline pressure tachycardia? If so, it's causing hemodynamic impact, regardless of whether there's collapse, regardless of whether there's right atrial systolic collapsed or not. That's almost secondary then. And so if you think that this is causing hemodynamic effects, it needs to be drained, regardless of whether those findings are there.
So take home message from this case will be, it's not only the looking at the echocardiographic pictures or the clips, but put everything together, including the history, examination, and what is in front of us, rather than looking at only the echo findings. And this was another interesting case of yours, Ross. Please.
Yeah, I mean, in this case, there's kind of a large pericardial effusion, particularly towards the apex. And I think the take home for this would be, if you're going to drain an effusion, think about what direction it makes most sense to drain it from. Now, at least when I was an internal medicine resident, when we were taught to do blind pericardiocenteses, we were told to go subxiphoid because that would be the safest blind window for a pericardiocentesis. But the challenge with that is you're going through the liver for that. And I've seen several pericardiocentesis related liver lacerations that required like bleeding and ORs and stuff as a result of it. And so if you have the luxury of time and you have an ultrasound available, I try to look peristernally, apically, and subxiphoid to figure out what would be the safest approach. And in this situation, there's almost 4 centimeters, 3 to 4 centimeters at the apex. And so I would try to locate that with the ultrasound and then go in from there over peristernal or subxiphoid in this situation. And I think that by doing that, we probably minimize the chance of complications. Because, and just for context, and I know that performing pericardiocenteses is something that is nerve-wracking, it's a rare procedure, it's high acuity, you can hit the heart, there's a lot of bad things that can happen. But in this situation, if you find the apex of the heart and the effusion, you have 4 centimeters. That's a lot of needle you can put in before you hit the heart. And so if you were coming in from there, you would be very safe to enter in. Enter in as long as you're keeping track of your needle tip and you're not hubbing kind of your needle when you're not paying attention. And if you've done thoracenteses, if you've done central lines, the needle motor skills and the Seldinger techniques should be fairly preserved.
Excellent. And when it comes to the cardiac tamponade echocardiographic features, obviously there is some quantification techniques. And I think this is the same patient, isn't it? The previous patient?
I'm not 100% sure, actually. I can't remember off the top of my head. But what this was actually a case report that we published. And this was a little bit different for 2 reasons. So the first was that traditionally we've relied on echocardiographic features of mitral valve inflow variation, tricuspid valve inflow variation, and some people have even discussed LVOT VTI variation. And that's the surrogate of stroke volume. And the idea relates back to ventricular interdependence, where when you breathe in, you should have more filling of your right side, but when there's a fixed space for the heart to kind of operate in, when you have more filling of your right side, you have less filling of your left side, and then less left ventricular stroke volume. This kind of challenges that a little bit and says, well, instead of looking at the heart, why don't we look at another vessel in the body that's even more easily accessible? For example, the carotid artery. And we could look at something called corrected flow time, which is essentially a surrogate of stroke volume. And what we could see is that in panel A on the top left there, pre-pericardiocentesis, there was an exaggerated change in stroke volume in the carotid during inspiration and expiration. So during inspiration, it would fall, ventricular interdependence, and during expiration, it would rise up again. And then after we performed the pericardiocentesis, and I say we, it wasn't myself, but it was one of our co-authors, after they performed the pericardiocentesis, you can see that there's much less variation in stroke volume as indicated by the carotid Doppler. And so this shows that perhaps for a patient where you don't have echocardiographic views, you just can't see anything, maybe this would be another way to assess the hemodynamic impact of a pericardial effusion. But there's something else that's quite interesting here. And if you actually look below the baseline, you can see that there's another tracing there. And that's actually the jugular venous Doppler, and it's present both in panel A and in panel B. And one of the things that on jugular Doppler here is if you look at the signal intensity in panel A between the jugular signal and the carotid signal, you'll notice that the jugular below the baseline is a lot brighter, and then the signal above the baseline is a lot less bright. But if you look at panel B, you'll notice that the ratio of the signal intensity is much more similar. They're both a lot brighter. And actually, signal intensity in the jugular Doppler is correlated with venous congestion. And this, as well as some other kind of experiences we've had measuring venous congestion markers during cardiac tamponade pre and post pericardiocentesis, shows that in addition to the impact on the arterial circulation or the forward flow, there seems to be elevated venous pressures related to pericardial effusions. And you know what? Taking kind of a little bit of a tangent to venous congestion is the concept that high venous pressures can reduce organ perfusion. We know intuitively that every organ has a perfusion pressure. Think about the brain, the cerebral perfusion pressure is the MAP minus your ICP, the inflow pressure and the outflow pressure. Well, it turns out other organs like the kidneys, for example, also have perfusion pressures, the MAP minus the central venous pressure, the CVP. And it's this perfusion gradient that drives, or it's this blood pressure gradient that drives perfusion. And increasingly, there's evidence in various populations, sepsis, cardiac surgery, that high venous pressures actually cause organ dysfunction. And what we've seen actually, and this kind of case report shows, is that early on, potentially in cardiac tamponade, we might see more venous congestion, and then later on, we might see more forward flow issues, impaired stroke volume. And this might explain why some patients with large pericardial effusions are sick, but they don't have the classic features of tamponade that we talk about. Maybe their mitral valve inflow variation and tricuspid valve inflow variation aren't quite at the threshold. Maybe their LVOT VTI isn't quite at the level that you'd expect to cause tamponade. It's still relatively normal, yet the patient has worsening renal function as a result of their pericardial effusion. And when you drain the effusion, that gets better. And certainly our group, and is an area of research interest for us, we're interested in understanding more about the role of venous congestion earlier on in pericardial effusions before they get to classic tamponade. And it really just comes back to the fact that tamponade is just a pericardial effusion and organ failure. And if you're very early in the spectrum, maybe venous congestion is the primary pathogenic or pathophysiologic mechanism that causes organ failure. And then maybe later on, it's more impaired stroke volume. These are certainly big questions, and we're trying to answer them. There's other groups trying to answer them, but at least this integrates into how I think about pericardial effusions just in general.
So pericardial effusion is not only the problem in the heart, but it is affecting multiple organs, isn't it?
Absolutely, yeah, and it's affecting multiple organs eventually due to poor forward flow, but perhaps initially due to high venous pressures. And we saw that based on the jugular Doppler here, and we've seen that measuring Doppler in the portal vein, hepatic vein, and intrarenal vein when we do Dopplers as well.
The Vexus.
Yeah, exactly. The Vexus score, or just considering venous congestion Doppler, because the Vexus score is that specific criteria that was derived in the cardiac surgery literature, whereas venous congestion Doppler more generally encompasses some other measurements and other thresholds.
Excellent. Thank you. And we have got this interesting case of yours where a transesophageal echocardiography was done.
And so this was a case post-cardiac surgery. And I just wanted to mention that post-cardiac surgery tamponade is different than medical tamponade in some ways. And so typically in non-cardiac surgery tamponade, the pericardial effusions are circumferential. And because they're circumferential, this whole idea of ventricular interdependence really holds true, where filling in one side of the heart impairs kind of ejection from the other side of the heart. In cardiac surgery, all bets are off because there can be bleeding and hematoma around any specific chamber, either the ventricles or the atrium, or even the upper mediastinum and superior vena cava, that can cause compression and local compression. And so in these situations, you really have to go chamber by chamber evaluating for blood. And so in this transesophageal echocardiogram, you can see the 4 chambers. So up at the top of the screen is the left atrium. On TEE in the esophagus, the left atrium is always right next to the probe. And then underneath that is going to be the ventricle, the left ventricle through the mitral valve there. And then there's going to be the right ventricle across the interventricular septum. And then the right atrium we can see just on the left of the screen there. So you might look at this and be like, like this actually looks okay. Like I can see all the chambers, they all look good. But with cardiac surgery related tamponade, always double check. And so I truly go every chamber by chamber and really have a really good look. I think there's another clip coming up here. So on that same patient, when we actually moved up to the right atrium and we went a little bit higher and changed the angle of our ultrasound, the omniplane, where the cursor is right now, that should be a large kind of black right atrium in there, a hypoechoic right atrium. But instead, there's this large kind of iso to hyperechoic structure, I guess, anterior to the right atrium. Well, actually, so down on the screen a little bit more, because anterior is flipped from peristernal. So deeper in this image is more anterior, and so actually even a bit down from there where you're pointing, all of that is actually tamponade outside of the right atrium, anterior to the right atrium, compressing downwards on the right atrium and causing tamponade. And so that may not have been visible from the previous view, but certainly is visible from here. And that's causing profound tamponade. But this could be the only view that you see that compared with a medical pericardial effusion where you can see it from most views.
So just to recap, so that's the right atrium, and that's the probably some blood, it looks like isoechoic, so maybe a bit clotted, and that is causing the pressure over the right atrium almost like collapsing, and so this is cardiac tamponade.
Exactly. And post-cardiac surgery, because these patients typically have mediastinal chest tubes in place, most of the tamponade, the hematomas that we see are isoechoic because they're clotted, because if they weren't clotted, typically the blood would exit out the tube. So it's when the blood clots and forms this hematoma and forms more clot around it that we start seeing the compression. And so this is classic kind of right atrial tamponade in the setting of post-cardiac surgery.
It's a beautiful picture there. And this is a classic presentation, isn't it, Ross?
Well, this is a classic presentation of a pericardial effusion that's not causing tamponade. And so this is a bit of a trick one. And so this is one where you might look at it and you might say, all right, this looks like there's going to be right atrial systolic collapse and diastolic collapse. But if you actually slow it down frame by frame, the collapse that we're seeing on the right ventricle is actually during systole. That's just normal right ventricular contraction. And the reason why it's more apparent, and I've seen people get fooled by this, is just that there's a pericardial effusion kind of silhouetting it and really drawing attention to the free wall of the RV. And same with the right atrium as well. There's kind of collapse there. But that is actually probably just normal kind of movement of the right atrium. And just normally we don't kind of visualize the right atrial wall there. Because there's no effusion there. So our eyes aren't kind of really used to it. And so this is a fairly normal echocardiogram, but I can't remember in this case, and maybe you can remind me, whether or not the patient had features of tamponade. Because if the patient had features of tamponade, then this could still be causing hemodynamic significance and might need to be drained. But if the patient was totally asymptomatic, which I suspect this patient probably was, given that kind of the normalcy of this echo, then you wouldn't have to do anything.
And if you can correlate the wall of the right atrium with the tricuspid valve, we can clearly see that this pseudo collapse is actually happening during the atrial systole rather than the diastole. Is correct?
Exactly.
All right. So another transesophageal echocardiography, and that's obviously we can see the pericardial effusion, which is anechoic this time. Was it a post cardiac surgery, or this was a different type of patient?
I think this was a medical patient here, or maybe even a trauma patient. And so we did a study locally where we looked at acute resuscitative transesophageal echocardiograms performed during trauma resuscitation. So this was in the trauma bay or shortly after ICU arrival, performed during resuscitation of trauma. And we actually found a number of pericardial effusions, some of which weren't apparent on surface focus just because of maybe there was subcutaneous emphysema or the patient had bad views. And so the first take home from our study was that perhaps there's a role for transesophageal echocardiography in addition to traditional POCUS in the trauma bay, which was interesting. But I think this would be an example where it appears that there's kind of impaired filling of that right ventricle, which is at the bottom of the screen there. It looks like it's being compressed, and without kind of being able to pause the frame too much, I would be very suspicious for tamponade. The heart kind of has a wiggly property to it. And when the heart looks a little bit wiggly and squirmy, often that's a sign of the ventricular interdependence. And even without measuring too much more, if it looks really kind of squirmy, you might think that that's tamponade there.
Thank you, Ross, for sharing that one. And you have got another post-cardiac surgery patient with transesophageal echocardiography.
Yeah, and so this one post cardiac surgery is interesting as well, because at the top of the screen we always have the left atrium, so you can see that up there with the left ventricle. We don't really see a lot of the left ventricle there. There's some shadowing there, but it doesn't look very filled. It looks pretty empty. That would be kind of my impression. And there's some left ventricular hypertrophy, and kind of the septum's quite thick. And then you can see the right ventricular free wall, but the RV also is not filling very much at all. And posterior to the, or I should say kind of anterior, because again, posterior is towards the top of the screen on TEE, but adjacent to the RV free wall, there's actually another isoechoic structure there. And that structure, you might think is just a really thick RV free wall, but you can see a little bit of anechoic fluid right there, and that makes you think that maybe there's a clot there. And then a bit more in the far field is a hyperechoic line, which is the pericardium. So we have pericardium, a bit of something, and then the RV free wall. And so in this case, it was actually clot adjacent to the right atrium and the right ventricle that was a little bit more subtle to see because it had similar echogenicity to the RV free wall here.
That's an excellent picture. I mean, so sometimes it can be quite difficult, but this little bit of anechoic fluid outside the right ventricle that really distinguishes this pericardial effusion, or clot rather, causing cardiac tamponade.
Yeah, and I think that this is a great illustration of why cardiac surgical tamponade takes a little bit of a different skill set than traditional medical tamponade. I encourage quite literally anyone to pick up an ultrasound and rule out tamponade on medical patients. I think it's easy to do. There's excellent evidence demonstrating that it's highly accurate. It saves time. It saves lives. It's truly one of the most iconic use cases for point of care ultrasound. After cardiac surgery, the skill set required to rule out tamponade is a little bit higher, and TEE is certainly a skill set that we promote at our institution for any resuscitative clinician in the emergency department, ICU, or anesthesia, to, when you have a patient who's dying, put the probe down and figure out what's going on. But ruling out tamponade requires a little bit more of a methodical approach and probably a little bit of additional training or mentorship to make sure that you're not missing kind of those really regional presentations of tamponade that are a little bit different than the traditional tamponade that we all learned for transthoracic echo.
Thanks, Ross. I believe this is the same patient with different views, and this is the apical four-chamber view.
Yeah, this is an apical four-chamber view, and I think this clip really just shows that the best approach is going to be from the apex there. You're going to have the thickest kind of amount of pericardial effusion to tap into. Mm-hmm. And these would also be patients that if there was lots of septations and you were wondering the etiology, a question could be had whether or not a pericardial window is potentially appropriate. Although, again, that's probably a discussion between cardiology and ICU and medicine and thoracic surgery or whoever does your pericardial windows. Just because there's fibrin does not mean that you have to do a window. I want to make that clear. But depending on the clinical situation, you just want to ask whether or not, or at least have in the back of your mind that there is a surgical kind of option available for some of these patients if it makes sense clinically to treat an infection or some other cause.
And as far as I can remember, this is the same patient in the apical, this is the parasternal long axis view.
Yeah, and I just really like this clip because there's a lot going on here. So in the near field, there's the pericardial effusion. You could see how a parasternal approach to draining this would also be appropriate. There's kind of 2 centimeters there, but there's more at the apex. And so typically I'll go apical if I can over parasternal. Then you can see the right ventricle. Then you see the left ventricular outflow tract down below the right ventricle. Right ventricle up there, left ventricular outflow tract. And then you see the left ventricle kind of in there. And then you see the pericardial effusion in the far field, and there's certainly a thicker pericardial effusion posteriorly than anteriorly, which makes sense if it's gravity dependent. And then even further than that, there's a pleural effusion, and so there's a left pleural effusion in the far field there. And so how we can tell that that's a pleural effusion and the one above it is the pericardial effusion is we look at the descending thoracic aorta. And so the descending thoracic aorta is our landmark there. And if the effusion tracks on the heart side of the descending thoracic aorta, then it's going to be the pericardial effusion. And if it tracks posterior to the descending thoracic aorta, it's going to be a pleural effusion. So I just really like this clip because you can really see everything and all the anatomy all at once.
Excellent clip there. And this is such an interesting clip for the trainees who are learning the echocardiography. So descending thoracic aorta, in front of it, that is the pericardial effusion, and behind it, that is the pleural effusion. Fantastic clip, Ross. Thanks for sharing that one. And this is the same patient with the parasternal short axis view.
Yeah, I don't know if I have too much else to add, just kind of another view of it there.
Yeah, that is excellent. And this is the subcostal view, the same presentation, same patient with, we are looking at from a different angle. Excellent. So thanks for sharing those interesting cases, Ross. You have mentioned about pericardiocentesis. Tell us a little bit about the overall management of the cardiac tamponade. What do you do in real life if you find a patient with cardiac tamponade?
Yeah, I think the first thing is to, again, go back to the fact that tamponade exists on a spectrum. To me, tamponade is just organ dysfunction related to pericardial effusion. It starts mild, where there might be mild congestive injury to the kidney, maybe the patient just feels a little bit dyspneic, and then it goes all the way to the patient being totally symptomatic, hypotensive, and in shock. And so the degree and the timing of intervention will depend on how critical the patient's presentation is. And it will also depend on what the etiology of the effusion is. So for example, in trauma, where you have an acute hemopericardium, the solution is not going to be a pericardiocentesis for this patient. It's going to be a thoracotomy and or pericardial window, some sort of surgical opening of the pericardium to deal with the tamponade. And you could see from the post-cardiac surgery TEE images I had there, you're not going to get much blood out if there's a big hematoma there. If it's already clotted, a pericardiocentesis isn't going to help. And so in those patients, due to high failure of pericardiocentesis, the solution might be surgery. For other crashing patients that are just kind of deteriorating right in front of you, I think of it as temporizing measures and then eventually kind of the drainage. Temporizing measures you can try are IV fluids to increase the preload to overcome that pericardial pressure. Related to that is vasopressors. So crank up the vasopressors, again, trying to recruit that venous volume and push it into the pericardium. But very quickly, that's going to be ineffective, and the solution is ultimately going to be to drain it with pericardiocentesis. And we can talk about some tips and tricks there if we want. On the more mild end of the spectrum, it can be a little bit tougher because some of these patients where they have a pericardial effusion, some mild organ injury, might not warrant or might not yet warrant a pericardiocentesis. So sometimes in these patients, I've seen them managed with IV fluids. I've seen them managed with diuresis, although you have to be careful diuresing big effusions that are on the borderline of kind of pericardiocentesis. If it's an inflammatory pericardial effusion, maybe some pericarditis, I've seen anti-inflammatories used. If it's autoimmune or rheumatologic, I've seen kind of steroids or other immunosuppressants used to kind of manage the underlying inflammation of the effusion. But as the patient starts having hemodynamic collapse as a result of it, you got to drain it.
And this drainage is not only therapeutic, but also diagnostic. So we can send it to the lab to find out whether it's infective, inflammatory, or malignant.
Absolutely, yeah.
There are a lot of research going on. Obviously, you have got significant contribution on this topic. What do you find about the current trend on the research on this topic?
Yeah. Now, I don't want to overstate my own kind of involvement in the pericardial effusion tamponade space. We've certainly published a few small papers on it. I think one of the things that I'm particularly interested in is the role of venous congestion as an early pathophysiologic mechanism for organ dysfunction in tamponade. And we see pericardial effusions that are 1 centimeter, 2 centimeter chronic effusions that don't have the classic echo features of tamponade, yet the patients are symptomatic. They have ileus, they have their stomachs feel distended and bloated. They have renal dysfunction, like a mild kind of congestive acute kidney injury. I'm really interested in understanding how to diagnose and treat these patients because I feel like many of them might have early venous congestion. I think there's also probably a question about timing of pericardiocentesis and when we should intervene. I think sometimes we intervene when patients are totally decompensating, but often these patients, I think, depending on their underlying cause, need intervention sooner. So I think there's still questions in the literature about the optimal timing for intervention. And I think that all comes back to the fact that it's a spectrum. And whenever you have a spectrum, the question is, where do you draw that line for when the patient should be intervened on? And that's going to depend based on your experience or your local facilities experience and available expertise, in fact, to drain the effusion, but also kind of your own biases as a clinician to being one of kind of more hands-on and aggressive or a little more conservative.
And also I noticed that this transesophageal echocardiography, which can be different from the conventional transthoracic echocardiography, that those different views and different findings, they can be quite some area to explore.
Absolutely. And I mean, we've studied transesophageal echocardiography in multiple different contexts: cardiac arrest, critically ill patients, trauma patients. And I think the take home from that would be it's safe, it's easy to perform even with limited training. And in some ways, it's easier to perform than surface echo because all you need to do is once you get the probe down, the heart's right there. You can't miss it. You're always behind the left atrium. And so getting that perfect 4-chamber view only takes maybe a couple minutes of optimization. And then once you have it, you can monitor it serially. You can guide pericardiocentesis, which I've done with TEE, where you can actually see the wire in you have somebody else doing the TE, and as you enter into the pericardium, you can see the bubbles and see the guide wire being introduced in real time, and that's pretty cool as well. And I feel like perhaps adds another layer of safety as well.
Thank you. What advice would you give, Ross, to the clinicians who are learning this particular topic of cardiac tamponade or pericardial tamponade?
Yeah, I think that that cardiac tamponade, people get too caught up in the definition. And I think this is a great kind of example of how in medicine we try to dichotomize things into disease present and disease absent, but really many diseases, and in fact most diseases, exist on a spectrum. And because we as humans can't deal with spectrums of diseases very well in our minds, we often want to put them into different categories, but really just kind of embrace the fact that many diseases in medicine exist on a spectrum. And tamponade is the perfect example. People have pericardial effusions that have a little bit of organ impairment or no organ impairment, and then people have pericardial effusions with complete circulatory collapse or cardiac arrest, and then every amount in between. So when somebody says, if you consult cardiology because you see an effusion and there's some organ failure and you're like, hey, I wonder if this is tamponade, and they say, oh, this isn't tamponade, there's no tricuspid valve, there's no mitral valve variation, don't be discouraged, because that patient, even though they don't meet that clinician's definition of tamponade, might still have an important pericardial effusion that needs treatment. And so just, embracing kind of the spectrum of disease presentation, because this is just such a hallmark in medicine, and tamponade is such a great example of it.
I really like your definition of cardiac tamponade, that this is not a single disease, it's a spectrum. And depending on the patient presentation, it can be at either end of the spectrum. So to summarize, cardiac tamponade is a very important topic. It's a time-critical, life-threatening emergencies. Sometimes we need to identify this rapidly by incorporating the clinical picture along with the echocardiographic features and other investigations. And this is an evolving topic, and we are learning day by day different aspects of it, and it will be very interesting to see what comes in the future.
Absolutely. And thanks again for having me to talk about it.
Thanks, Ross, for taking your time. Thank you very much.
All right. Have a good night.
Thank you.